Well, thank you very much. I greatly appreciated the opportunity to come and talk with you. And I have to tell you, after listening to that last talk, I'm really jealous of you all that you get to stay here all week and have this kind of opportunity. For me, this is a little coming home because I actually graduated from the School of Organization and Management, so Yale's business school, a school of public management. And the things that I learned in that class, in that 2-year program about management and experiencing working emotional intelligence, how to present, how to construct a compelling argument, think strategically, have been things that I have drawn on throughout my career. And I have to say that during this 20 years, I've also had some opportunities to have some special kind of sit back, withdraw from the technical environment I'm in, and sit and have some leadership and management training. And I have, every time I've had one of those opportunities, found it incredibly valuable. Because so often we're caught up in our day-to-day, and to have a chance to step back and actually talk to peers, learn from how they're approaching different problems, think about things from a different angle, can be so incredibly valuable. So I think you all are extremely fortunate to have this week, and I feel very fortunate to get to share at least a small part of it with you. What I wanted to do is briefly take you through some of what the U.S. Global Health Initiative is, a little bit of the context of how did the U.S. government arrive at this, and then also some of what is it. But what I want to do is keep my talking on these points sort of to a minimum to allow a maximum amount of time for us to talk and discuss what you're seeing, what you see as key issues, and also what you've seen from how the U.S. government it has been working with you in your countries, and ways that you think we can improve that, ways that you think we can be changing the way we approach it to be more efficient, more effective, more focused on building the kind of capacity to take forward your programs. So that's where I want to save the bulk of the time, and I hope, please don't hesitate to ask questions as we go, but also we'll have a lot of time at the end to be discussing these different issues. Am I double mic'd here? Is it too much? No? Okay. I also was very struck by the different problems that you've each identified as areas that you want to go forward and focus some of your attention, and recognizing that these are such critical aspects of being able to achieve the kind of health objectives and priorities that your governments have set and that the U.S. government is committed to helping to support. And so being able to go from the generalized into the more specific seems like a really valuable opportunity. So first, why even a global health initiative? The U.S. government has been and continues to be highly committed to global health. In fact, here you have a quote from President Obama from last year when he launched the Global Health Initiative, where he was not only talking about the importance of achieving global health today, but even more that if we want to be able to go forward, we need to be having sustainable programs. So he said, we will not be successful in our efforts to end deaths from AIDS, malaria, and tuberculosis unless we do more to improve health systems around the world, focus our efforts on child and maternal health, and ensure that best practices drive the funding for these programs. So it was a program where he was really taking the experiences and the tremendous success of his predecessor, of President Bush, who had really upped the game in terms of the levels of investment he was putting through the U.S. government for AIDS, for malaria through PEPFAR and PMI, but taking it even a step further and building on that leadership by focusing it on how do we ensure the capacity to go forward, that we're going to achieve these health, we can help support the achievement of these targets today, but be able to take it forward. So we've seen there's been quite a big change over time in terms of the level of health of investments around the world to support your programs. This isn't even capturing the changes within your own government budgeting or the large amounts of bilateral fundings that are provided through various groups. But we've seen the advent of the Global Fund. We've seen the Gates Foundation come on the scene and really change some of the funding flows. We've seen Gavi, and of course things like PEPFAR and PMI. And out of this, we've seen some real improvements in health. And I think the level of attention that the world has brought over the last decade to global health programs and working with national counterparts to make a difference has been quite extraordinary. But of course, what comes as no surprise to you is that the challenges are still extremely significant. And part of the issue, or probably the fundamental issue with this challenge is we have a lot of technical knowledge about how to tackle each of these diseases. There are a lot of different sort of technical strategies. The sort of biomedical approach to these problems is actually fairly well known. The biggest problem is the underlying capacity to deliver all of that known knowledge, the management, the leadership throughout the system to ensure that the priorities are set, that the focus is there, that the human resources for health are trained and in place, that the financial systems and the flow of funds are following it, that in the end of the day, we not only have trained health workers, we not only have drugs, we not only have facilities, but we actually have the right worker with the right training in the right place at the right time with the right drugs and equipment and with a knowledgeable population that is coming and demanding those services. And it's that combination of events which is, I think, missing. We have pieces of it. Every program has very many of the pieces in place. It's when they all need to come together to ensure that at the end of the day, that mother is delivering in a facility that we start to run into the difficulties. And in my experience, that all really comes down to the kind of management and leadership, which I think is what you're here about and the role that you play in your own countries. I would say, too, another kind of key learning that we've had about why we're not there and why these pieces aren't all fitting together falls back on the donors and how they've often engaged with you, where I know the U.S. government has been somewhat guilty of this, and many others as well, of taking more of a vertical approach. And by taking a vertical approach of looking at things as a disease, rather than looking at the patient and their full needs and making sure all of their needs are met, we've helped to fragment some of the programs and some of the health systems further. And I think that that's been an extremely important learning. And so as you look at, as we look at sort of what is the leadership of the U.S. government, what can we learn? What can we do differently? How can we play an optimal role in terms of engaging with you and other partners? It's about thinking about the value that's been brought to the table by virtue of having these disease-specific goals, of showing success, of showing the potential of what we can achieve, but at the same time recognizing some of the transaction costs we've created, some of the burdens, and how can we improve upon that. Now, as the U.S. has been exploring its commitment on global health, it's actually been a relatively tough period to be doing that in. There are enormous financial constraints. I think every country, including the U.S., is having a tough budget environment to work within. There are some massive new areas of attention, for example, climate change, which is extremely urgent and needs to take a lot of attention. There's food security, again, extremely urgent, and an area that we all want to put more attention, more dollars. So there's a lot of very important competing priorities. And global health really had the stage for 10 years, for a decade. And now there's a lot of other priorities that are kind of crowding that stage. Well, the good news is, for us, is that the U.S. government went through all of that thinking, and the President, Secretary Clinton, the whole sort of our chain of command is very, very committed to global health and continues to be extremely committed. And not only sees it for the health factor, but what's quite extraordinary is they actually see it as a fundamental part of the U.S. government approach to diplomacy and national security. So they've really elevated the issue of development, and in particular global health within development, to a much higher level than it's ever been before, frankly. And with that kind of leadership on our side, it means we can really approach and tackle some of these problems in new and different ways. One issue that's come to a fore is, I think, the recognition that globalization has had positives and negatives. And I think most of what we've seen in the press has highlighted some of the negative effects of globalization, the interconnectedness, and that when there's a financial crisis in one country, the whole world feels the effects. Well, similarly, clearly with health, there's a very significant global public good element, and when there is a disease, it knows no borders. But it goes further than that. It's also recognizing that when you have a healthy, happy population, when you have parents that can see their children thriving, you have a much stabler world. You have a much happier, more peaceful world than when you have parents who are watching their children die before they reach the age of 5 or 10. Or countries that are ravaged by disease and have no hope. And I think it's that understanding of humans, of how each individual in the population, not how the national government, but how the people in a country see happiness and see the stability, see the rights of being a human and having their children grow up, that I think is really driving some of this thinking. And what they're calling smart power is the U.S. has a lot of wealth, it has a lot of voice, and it needs to use that very, very responsibly. And it needs to use that power in a very smart way. And this is part of the thinking driving that. I think what's also gone on as the U.S. has looked at the stage of global health is the understanding of that there are different, it's a humility factor. It's a recognition that to achieve the kind of objectives that the world wants to see in health, there are a lot of actors. There are a lot of different leaders in different areas that have critical roles to play and that bring different skills. And the U.S. is one of those actors. But the U.S. cannot do it all by itself. I think that's self-evident for everyone in this room, but sometimes it gets lost in the halls of Washington. And there's this recognition of how can we be thinking about achieving these kind of goals of global health that we'll talk about in a minute, but first and foremost recognizing the country-level partners. And not just at the national level, but very importantly down the chain to the district and probably most importantly at the community level. Recognizing the critical role that governments play in setting priorities, in determining strategy, in overseeing what's being done, in deciding the flows of funds, and ultimately in being accountable to its population, but also recognizing that there are a number of other players in every country that play extremely important roles. There's the NGO community, the FBOs, the faith-based organizations, civil society down at the grassroots level. All of these groups, incredibly important roles, not only in sometimes delivering the services, but also in bringing to bear new skills, in assuring a level of transparency and accountability, in helping validate whether those services were indeed delivered or not, in raising the voice back to of the population back to complete the chain. The private sector. Lots of discussion about what is the most appropriate role of the private sector. The bottom line is in many countries, the poorest families, up to 40% of the funds that they spend on health are going into the private sector. The private sector is playing a very big role in the provision of services. And the importance of ensuring that those are quality services that are aligned with best practices becomes extremely important. But also in a more positive sense, the private sector has a lot of resources, it has a lot of different skills, and being able to harness some of those can become tremendously valuable. We can talk a little bit, but I've been very struck about some of the examples of what I've seen in countries of where, for example, mining companies in Africa, who are now recognizing that the cost to pay for ARVs for a patient with AIDS, for an employee with AIDS, is cheaper for them than having to have a sick employee and ultimately find a new person, retrain that person, and get them up to speed on the job. Very hard-bitten economic argument. And yet, incredibly valuable, because if it means a company's going to start paying for ARVs, we have a new source of financing for what's one of the most tricky problems of how do we get more people on treatment. So thinking creatively about the different roles that these different stakeholders play in a country, I think is a very important thing and is a very big part of government leadership. There's also for us the global partners. And I know in each of your countries you reflect on the sometimes conflicting advice or sometimes highly complementary and supportive advice, but also at our level in working at the global is the different multilats, WHO, the World Bank. What do they bring? How can we work with them? How do we identify relative comparative advantages? The bilaterals, the government of Norway and Netherlands and France and the G8, the foundations like Gates, private sector, and of course this other cast of characters. They're playing roles both national and global level. And this recognition for us in the US government that by aligning our goals and collaborating more effectively with these different groups, we can actually achieve much, much more than if we try and go at it alone. We can actually be mobilizing shared commitment and engaging these different complementary skills. So it was that kind of thinking that really formed some of the context in which the work around defining this global health initiative came into play. And as was mentioned, this GHI, I know it'll be a bit confusing with GHLI and GHI, but
there's a difference.
There is a difference, a $63 billion one.
I know.
Though if Yale had its way, we might reverse that. But so what we'll do is take you a little bit through what is GHI. It is this 6-year commitment for $63 billion to support a lot of different health outcomes. So it's really thinking not so much about the disease focus, but more about if a patient walks into a clinic, what are the needs that they have? What are the services that they require? We'll talk a little bit about some of the principles that are embedded in GHI, which I think is some of the most exciting aspects of it, because that's the what's different. How do we work differently, and I think have the potential to work much, much more effectively, smarter. So first is the issue of the targets. So GHI is building on, is a recognition of and is building on the successes of PEPFAR, of PMI, of the work that USAID and others have done in MCH. So it's building on that, what's come before it. It's not changed, it's not walking away from it. It's building on it. It's recognizing PEPFAR did an extraordinary thing. It fundamentally changed the amount of resources and the attention of the American population and of our Congress and of our administration towards some global health targets. And that's why it continues to build and set even more ambitious targets in the domain of HIV/AIDS. And similarly in the domain of malaria, where we had the President's Malaria Initiative. But what I think is truly exciting is GHI is all about saving more lives. And so in addition to ambitious targets for AIDS, malaria, TB, you also have ambitious targets for maternal health and child health, and neglected tropical diseases, and family planning, and nutrition. So it's really broadening out to be even more effective in terms of what we can achieve, and to be thinking more about the person with HIV/AIDS who goes into a clinic, who has more needs than just having her ARVs. She may be pregnant. And what a tragedy for her to be given the hope of having ARVs and then have her die in childbirth, or have her newborn die. So this is what I think is probably the most exciting part. It's this basket. It's this balanced basket that's really looking at the holistic needs. In addition, though, GHI is looking about how do you achieve those targets? And first and foremost, and as you saw in President Obama's quote, it's about doing it in a sustainable way. We don't want to just achieve some of these targets or support you to achieve these targets and then 5 years down the line have a decline. We want to ensure that these targets can be sustained and built upon. And that becomes an important question about how do you do it, right? You can have campaigns, you can fly in fleets of volunteers and achieve a lot in the short term. But when the volunteers go home, if you don't have an investment in the systems which you all are running, what do you have left? So I think that's the biggest change in this thinking is how do we ensure that we not only achieve those targets, but do it in a sustainable way that's about building capacity. And hence the first principle, supporting greater country ownership. And I'm looking forward to hearing many of your thoughts about how do we do it. Country ownership is one of those buzzwords that everyone likes to throw around that makes it sound good. But what is the difference in terms of how we do business on the ground to best achieve it? Recognizing the constraints that you face, the constraints that we face, because ultimately I have to go to my Congress and report how that money was used. So there are certain constraints that I'm going to face if I want to see more money in the future. But to get to that objective. Second is implementing a woman and girl-centered approach. Why a woman and girl-centered approach? We get lots of audiences where all the men raise their hands saying, don't the men matter? And of course the men matter. In fact, the men always get there first, so I'm not so worried about them. But with the women and girl-centered approach, it's really a recognition of oftentimes the women are the most marginalized, have the least voice, and have some of the biggest health needs that are unmet. In addition to the woman in and of herself, of course, is the very special role that she plays in terms of the health of her family and of her community. Because it's the woman that makes the decision to seek preventive care. It's the woman that makes the nutritional decisions in the family in most cases. And so she has a very special role that has a hugely contributing factor to the overall health in the country. Third is this issue of coordination, collaboration, integration. So this recognition of how we work with others is critically important if we want to be achieving these goals. How we work with you, how we work with other partners in country or globally, and also, quite frankly, how we work within the US government. Because there are different parts of the US government, and it's critically important for us in the government, if we want to work smarter, more efficiently and effectively, to be thinking strategically about, what is the unique skills that CDC brings versus USAID versus the NIH and its Fogarty program? What are those different skills? And how do we use them to best effect? Building sustainability, so this issue of how do we build capacity, how do we build health systems. And I think what we'll have to come back to, what's important here is, and I think as you all know very well, but it has been a point of confusion in the past, health systems are never an end in and of themselves. Health systems are a means to an end. But we've already gone through the period of the 90s where somehow health systems became the end point. And I know the World Bank had a lot of learning around this. Health systems became the end, and there was counting how many people trained, counting how many facilities built. But that point that I said in the beginning of whether you actually had those trained health workers in the right facility with the drugs they needed, with a population, and ultimately delivering the service wasn't captured. So coming back to that, how do you do health systems in a way that's meaningful and that results in actual changes in health? Improving metrics, monitoring, and evaluation, we'll come back to that. Mike noted we were laughing because Betsy was saying how, when Mike was talking about later in your program where you're really talking about monitoring, evaluation, and all of this, I had been saying earlier this morning that this is an area where we in the US government have a lot of thinking to do. And we can sort of, I'm sure you all know it from the number of indicators that you have to respond on and all the rest, and it's something we can, I'd like to talk about some more. And last is promoting research and innovation to identify what works. So what does that all add up to? What is new about GHI? I think to start with recognition that all of the principles I just laid out are what in the US there's an expression that's called Motherhood and Apple Pie, which means everyone knows that's what you should do. I don't think anything that was on that previous slide would be a surprise to anyone in this room. The issue is, though, we're not always doing it, And we're certainly not doing it consistently. We're certainly not doing it with a dedicated focus. We're certainly not doing it explicitly. Some of the trade-off decisions you have to make about achieving, achieving a target faster, or achieving it a little slower while building capacity, those kind of really tough choices have always been kind of under the table. And now we're trying to raise them into the day of, the sunlight. Say, let's make some explicit decisions here of how we approach these. So what's new is this very explicit recognition that we need to collaborate for impact. That we need to be working better, more effectively, in greater alignment with you, your governments, other partners in your countries, and with our various global health partners. Doing more of what works. Well, part of the challenge there is what works? Do we have the evidence base in all cases about what works, what doesn't? Especially when it comes to these issues of health systems. As I said, we have a lot of evidence actually on the biomedical side of things. But when it comes to behavioral change, when it comes to building more of a community-based platform, the amount of evidence actually in these areas is pretty thin. When it even comes to exciting innovations like performance-based financing, which Rwanda is playing an extremely important role in, which I noticed a couple of your governments are looking at. We have some great evidence, thankfully, from Rwanda, who did some really important evaluation work around it. But that's one country, and we need more. So this issue of let's do what works, let's not do what doesn't work, and let's admit which is which, and have the evidence base to support it, is a really critical issue. And I know in the importance of a leader, my boss at USAID, the new administrator, is Dr. Rajiv Shah, who's amazing and an incredibly compelling speaker, and very effective at bringing people along. But he looks at the culture of people not being willing to admit what doesn't work, which I'm sure anybody in a political environment, we certainly have it in the US government, I'm sure you all face it. You never want to admit what doesn't work. And yet there's so much learning in what doesn't work. There's so much learning in saying, we finally got here, but it took us 4 attempts. Here's the first 3 attempts and why they didn't get us where we needed to go, and what we learned, and how we corrected, and then how we use that to apply going forward. And oftentimes that stuff just gets lost. It's swept under the table and nobody ever acknowledges it. So he keeps threatening staff at USAID that he wants to hold a failure conference. And we keep saying, well, can we change the title at least? Great idea, but I'm not sure failure conference is going to get great attendance. But hold a failure conference effectively where it's about having people come in and celebrating, acknowledging the value of the kind of work that they've done, where it didn't ultimately get them where they wanted to go, but where there was the explicit learning behind it, and how that learning then informed what we did next. So that we weren't just doing the same mistake over and over, hopefully, but instead kind of taking it, building on it, and incorporating it into our strategic thinking going forward. And start trying to change the culture in my organization, in other places, so that that becomes a positive rather than currently where nobody wants to admit that they didn't achieve what they thought they were going to achieve. And I have to tell you, we're even getting that message from our Congress. So the people that ultimately decide, how much, what are the priorities that the U.S. government will be supporting in terms of our funding support and the appropriations and whatnot, saying we want to know what didn't work. We want to make sure that you're not just repeating bad mistakes over and over. And by acknowledging what isn't working, you actually give us some confidence that you're paying attention, you're collecting this data, and you're making wise decisions going forward. What else is new in this business model is this expanding the platforms. So this issue of health systems, strengthening, capacity building, well, one of the big pieces of that is integration. And I know in Africa in particular, many countries had programs, started your health programs which were around an integration platform. It was when someone walked in a primary care facility, they had all their services. And over time, in part because of the way donors have been very focused on achieving specific goals, oftentimes that's been fragmented out. So now a mother might walk into a facility and be told, sorry, this is just the HIV/AIDS facility. If you want antenatal care or obstetric care, you need to go down the road or into the village or into the district, especially if it's emergency care. And the mother may not have that option. There may be a lot of hidden constraints. She may not have the bus fare or the ability to assure the food for her family and for herself while she takes that extra time to go off. And so thinking about then, again, not treating the disease, but treating the patient and their full set of needs, and this issue about how can we really be thinking much more about this integrated platform and kind of coming back to that original logic, which is fortunately still in place in many countries. The issue of women and girls, which I was explaining a little bit of the health rationale behind, but what does it mean in this sort of new business model to focus on women and girls? Well, when Peter was talking about sort of where there can be a passion and using that passion with your technical knowledge for really driving forward in your leadership, well, this is Secretary Clinton's passion, is women and girls, empowering women and girls, meeting the needs of women and girls, really changing that picture is Secretary Clinton's passion. And because of her incredible leadership, you can bet everyone is making sure that this is something that we're really thinking about in new, creative ways. So it's an incredibly exciting opportunity. How do we tackle what's the age-old problem of not only addressing the health needs, but by trying to address health needs, one needs to be thinking about the social, cultural determinants, economic determinants that ultimately are behind whether or not she can even access the service, or whether she's had a voice in the design of the service to assure it meets her needs. And thinking creatively about how do we systematically remove some of those barriers. And this is an area where the US government is really excited to learn with countries who are pushing that frontier to see how do you do it? What does it really mean on the ground? And then sharing that with others. We talk about innovating for results. The innovation doesn't come from Washington or London. There's incredible innovations going on in each of your countries. And every time I've been struck when I'm down in the district, and there's some amazingly clever approach to some problem. And yet, the country doesn't even know it. Sometimes it doesn't even make it out of the sort of district environment. I mean, I was at a recent meeting where they had, it's about 2 years ago, in Zambia. And they had the district manager who had come up with this really, really clever way of bringing people in. One, as he said, is the food issue. So he started cooking to actually feed the clients that were coming to him to make sure that it wasn't food that was acting as a barrier for people coming to get health services. There was a whole issue about motivation and incentives. And he didn't actually have the budget to be doing something like performance-based financing. So he was looking at other forms of intrinsic reward, of how do you make a special recognition for the villages under his district authority to recognize who was doing what and acknowledge it and get some extra credit around it. Huge impact. Just something as simple as recognizing individual motivation, making a plaque, and having an award ceremony. And when this district manager was brought up to be part of a global conference, which had a whole delegation of Zambians, and he was sharing these ideas, and it was amazing. And it was really something that was sort of a level of innovation and leadership that hadn't been surfaced as much. And Zambia now is learning from that district, learning from some other places, and thinking about how can they go forward with something like performance-based financing, recognizing these issues of motivation and all the rest. And so it's trying to kind of, my view, innovation and the job of an entity like the US government is working with you to identify where you are already, you or someone in your country is pushing the envelope. What can we learn from Ethiopia's, the health extension workers? Amazing program. Many countries are facing the same kind of problems. A lot of learning in there. What can we take from Rwanda's results-based or performance-based financing program? Has had extraordinary impact in terms of the supply of services, the way health workers are treating the patients that come to them, because now it's, if the patients don't come, there's no reward. How can we learn from what each of you and other countries are doing, where you're each kind of taking an innovative approach and surface, and then ensure that there's the data behind it, and then share that broadly? What did you do? Why were you motivated to do it? How did it work out? What's the data to substantiate it? What didn't work? How did you handle the realities of the life, which are often forgotten by the Washington folks, of the unions? How can you do PBF, where you're changing the salary structure of health workers, when you have to deal with all the teachers and what this means on the education side of the argument? All of these sort of really, really practical issues, which when you're in the country, you've dealt with, but often get forgotten when you look at the sort of more academic models of these things. And that's the real value. So what we want to be doing is really helping to identify those things, helping to provide the support to get the evidence behind it, and then providing the fora so that you can exchange your own learning amongst each other, and we can learn while you're doing it. And that's what we think of as key innovation. I'd say importantly on the M&E side is the expression that you have in the business sector, which is you can't manage what you can't measure. And so we put a lot of weight on that. But at the same time is the problem we have now in public health, which is we're measuring everything, much of which we're not needing to manage. So we've actually overloaded the systems with all of these demands for the planning and the reporting, and every donor has a slightly different indicator, just different enough that it requires another whole exercise to collect it. And the problem with all of those indicators means that people aren't actually focusing on the ones that are really meaningful. You don't have the time. We don't have the time. Our staff in country their number one complaint, in fact, is the incredible burden placed on them, never mind you, the burden placed on them in terms of the reporting and planning requirements behind PEPFAR, behind PMI, behind all of these separate programs. And that's where something for us like GHI allows us to do some reflection and some learning about not only what we talk to you about, but how we think about it ourselves. And that's where this dialogue becomes very important. And hearing what you have to say so that we can ensure that the way we're approaching these programs is smarter. So how does GHI work? In general, for the US government, it's about a whole of government. So this issue of recognizing what different parts of the government can bring to the table and really maximizing that value. Integrating how we work. Focusing on creating greater country-level capacity. So that's the country ownership and the systems. Recognizing that we're building on existing programs and plans. So we're not trying to duplicate anything. We have to look at, for example, the planning and reporting that's already there, already overloading the system before we think about how can we actually do GHI. It's funny, in the US they have the PEPFARs are called in Washington the COPS. I'm not even sure what it stands for, but it's the COPS. And so then when the malaria program came along, they were the MOPS. And then there's another one, another whole reporting requirement that comes from our finance group, which they call the FOPS. So when we started talking about GHI, every field staff was like, please tell us you're not going to create the GOPS because we just can't survive. And that's been heard loud and clear. So thinking about that, building on these existing plans, programs, and seeing how can we be smarter, more rationalized in the approach. How do we coordinate better? How do we look at the existing agreements that are set up and the work with your national plans, your nationally set priorities and targets to take it forward? And above all else, not trying to create some sort of vertical program, not trying to create something which is the US government does it by itself, but really collaborating much more closely. On the operational plans, a lot of thinking is going into this and is still going into this. GHI and this $63 billion will be implemented in all countries, all 80+ countries where the US government has investments in health. So GHI is about every country. that we're working in. And many of the programs have already started to take on board some of these principles that we've that I've highlighted, and started to look at how their program can be tweaked and changed to better address that. But part of what we want to do is go faster and harder in terms of making progress towards change. And as you all know, changing how you do business is really hard in a political environment, in a government environment. So in addition to the real meat of this, which is GHI implemented everywhere, what we've done is set up this program called GHI Plus, and I know Rwanda and Ethiopia are both GHI Plus countries. But the objective in these Plus countries is to have some additional technical assistance, some additional management focus, so for example, my attention in particular, to see how can we really accelerate the implementation of GHI. How can we, when we talk about country ownership, let's not talk about it vaguely. Let's sit down in starting with these first 8 countries, which are the GHI Plus countries, and really get down into the details of what does that mean in terms of how we program our funds in your country. When we talk about a woman and girl-centered approach, let's talk reality of in different country contexts, given the socio-political environment in that country, what makes sense? What are the practical steps that can be done? What can we learn from that, and how do we share that? So part of what's going on with these Plus countries is really, some people refer to it almost as an intensified learning lab, that these countries really help us push a little further, a little faster, and then allow us to share all of that with all 80 countries so everyone can benefit from their learning. The way the Plus countries were chosen was not a good or a bad or a priority or non-priority. It was really all about where did we think there was a good opportunity for learning. So the first question there was, where is the government and other national partners and the team on the ground, the USG team on the ground, want to be a partner in this effort? Where was it a priority for them? That they were interested in this kind of learning responsibility and sharing this information with others and helping provide that kind of leadership role. So that became the first question. Then in addition, we looked at what were some of the different things going on that might be of real value. So where did we have the different programs, you know, Big PEPFAR, PMI, MCH, malaria, TB types of programs that we could be learning from in the integration issue. Where were there other sectoral programs that the US government was investing in? So for example, there's a whole Feed the Future initiative, which is about food security. So we wanted to make sure we had some countries which were doing Feed the Future and could be a GHI Plus, because where those two programs come together is nutrition. And the really exciting learning that can be going on in nutrition about how do you get the agricultural and trade guys to be thinking about nutrition as an endpoint, to get them to adopt a goal like stunting as a measure of whether they're achieving their food security goals. And conversely, maybe get the health group to adopt goals like, you know, is there a basket of, does a typical family have access to affordable basket of dairy products? So you're talking about food diversity. So trying to get those crossovers across the different sectors. Similarly, looking at governance type of programs, because ultimately this issue of a woman and girl-centered approach isn't just a health one. It's about the political issues, governance, empowerment of women, which goes way beyond the health sector. So looking for those kind of crossovers. Also looking globally. So where were there some really interesting learning opportunities globally? Like IHP Plus, the International Health Partnership Plus, which many bilaterals and multilaterals are part of, and it's about how can they harmonize and align better the way that they're doing business with governments. And we want to see how can the US learn from that. Or the health system strengthening platform that the Global Fund and the World Bank and Gavi are exploring right now. And what can we learn from that to see how we do business? So those were the kind of factors that were used in terms of identifying this first set of Plus countries. And there'll be, I think the intention is to have a second round of Plus countries around 2013. But then, working with these countries, but working with all 80 countries, what we're trying to do in GHI is actually just make the space for the effective planning on the ground. So it's not about, a dark room in Washington where people are defining this is what you will do, this is how it'll all look, but rather saying what we're doing is defining the operational plan with the country teams on the ground. So there's already been a visit to Kenya, a visit last week to Nepal, to start working with the country teams, meeting with national counterparts, government and others, to kind of get a feel for how should we structure these things. And then those will form the basis for the guidelines that are sent to all countries. And in fact, when I left Washington, I think they were in the midst of trying to plan for me to be going to Ethiopia very shortly, potentially next week. And so again, taking forward that conversation country by country so that we're learning by talking with the countries and designing around that. What they're thinking the plan might look like is GHI has these global targets that I outlined earlier. The first order of business is having these global targets, but having those translated down to the national level. So every country has its national targets from its plans. And looking at what are those targets, if there's room for dialogue, because if the USG comes in and says, if we provide extra support, do you think you might make this target a little more ambitious, that we can help you achieving it? But that ultimately it has to be a nationally owned target, and that should be set the where are we going question. Then once we know where we are going within the country, looking at the existing plans, so starting with the national plan and national strategies, but also looking at all of these USG plans that exist and having a sense of what are other donors and partners doing. So where are there gaps versus where are there a lot of players? To then think effectively of, if this is where we're going and this is what we've got on the table right now and where we are, what needs to be changed? Where aren't we going to get because of the existing plans aren't adequate? Where do we think, where's the government and other partners and the US team think we need to push on the frontier? And then that's how we want to be driving forward the plan more, okay? Building on these existing plans. And lastly, and particularly for the plus countries, but it's something we would support in every country, is out of that picture is having a learning agenda fall out. So they'll be monitoring, and we're trying to streamline all the monitoring and planning that's going on. But there's some really valuable learning that we want to capture. So of that area that was identified as the key areas to be really pushing, shaping, piloting something new or scaling up something that everyone's very excited about, which of those areas would be really valuable to have some extra learning? Well, we want to make sure we have the baseline data so we know where we are and then we can tell where we got. Where we want to have a really well-designed for-purpose type of study, whether it's the super rigorous evaluation or something that's lighter, more timely, more focused, depending on what the issue is. And so that we can focus some of this additional technical assistance and management attention on capturing those things. So at the end of the day, we have these lessons learned that can be shared more broadly across the world. So that would be what it would, the plans overall would look like. In the longer term, what we hope to have is one GHI plan. So instead of the COP and the MOP and the FOP and all of these other things, we would have one plan that kind of captures all of those different pieces. But it'll take us a while to get there, as I'm sure you can imagine. So going forward, I think there's a lot of room to be working together in a new and I think more higher impact way. And we're very excited to have that dialogue and hear what you have to say. And I'm particularly excited to be here now so I can take some of this back with me as we're in this very active period of thinking, learning, and trying to design. I identified a couple of topics that I'm interested in hearing about, but I'm very happy to talk about anything with you. But one is, how can the U.S. better support country ownership? What does that really mean in your country context? Some discussion around the respective roles within your countries, what you see from other countries, but about how to really maximize what the government brings to the table with what NGOs, FBOs, the private sector, civil society, the communities themselves what the roles can be, what they are now and what you think they can be in terms of really achieving your targets. And then how can we help you to achieve that, to help strengthen some of that capacity? Some sharing of some of the new ideas to old problems, and the issue about how do we make sure we're getting that evidence base to substantiate what we're really excited about and to share it in a more meaningful way so that your governments have the data necessary, so your Minister of Finance has the data necessary to make a big decision about allocating resources to support a scale-up if that's appropriate from your decision. So other governments are in a position to know what you've done, why, how, and what the impact was, and have a compelling argument. And frankly, so that donor partners like the US and others can be learning from it and aligning our funding in an appropriate way. And then the last big question I put down was, how are we strengthening systems while at the same time we're really increasing the focus and the accountability for results? And frankly, I don't even talk outcomes, impact, intermediate outcomes, outputs. I mean, the conversation can go on forever, and I've had it forever with the World Bank and WHO. So I just want to talk results, and we can define what those results mean. But how are we really assuring that we are achieving the right kind of service delivery to the right population to achieve the kind of health impact that you've set as priorities? So I'll stop there, and then we can just open it up for discussion.